Thank you for viewing this video on the virus COVID-19 registry. Just some quick introductions. I am Dr. Smith-Hevner. I am the Scientific Director of the Cure Drug Repurposing Collaboratory. I'm also an adjunct assistant professor at the University of South Carolina School of Medicine, Greenville. And I am the chair of the Virus Practical EHR Export Pathways, the subcommittee focused on automating data extraction in the virus COVID-19 registry. Please feel free to mention me on Twitter at Swiss Army Nurse. And I also have with me Dr. Rahul Kashyap. I'll let him introduce himself.
Thank you, Smithy. And again, if you are live tweeting while watching this video, Smithy at the Swiss Army Nurse and myself as Dr._SR Kashyap. My name is Dr. Rahul Kashyap. I'm Division Director for Research for TriStar Division for HCA Healthcare. I hold an academic rank of Assistant Professor in Physiology at Mayo Clinic as well. And I have a pleasure of serving as a co-PI of virus COVID-19 registry along with Dr. Kumar and Dr. Walkie from BU. Happy to be here. So as an introduction, I'm sure you might have heard by now in last 2 years about the virus COVID-19 registry. Virus stands for Viral Infection and Respiratory Illness Universal Study. It is a cross-sectional observation study of all eligible COVID-19 patients who are admitted to the participating hospitals. The registry is registered at clinicaltrials.gov as well, and please feel free to check in our dashboard at sccmcovid19.org. This registry is no intervention. It includes only patients who are included in the admitting hospitals. De-identified data collection either manually or through automation, and Smithy will talk about that at length. In the beginning, we started collecting data on patients who were COVID-19 positive or have high clinical suspicion. But eventually, more than 97% of our patients are COVID-19 positive. So there are very few patients which should not been included in much analysis. To give you a summary, we claim to be one of the accurate, generalizable, near real-time data on COVID-19 practice variations and outcomes. And then quickly it became one of the largest United States COVID-19 registry. To give you a glimpse of what registry was, it has been published in Critical Care Exploration, but when you see the timeline from 2020, starting at March 11th, where the idea was conceived and followed through the processes of inviting PIs and co-PIs, and teams were formed, the protocols were written and refined. IRB was submitted like within 9-10 days of this time on Friday evening. I still remember that. The red cap data collection form, the case report forms were created and designed. Social media accounts were set up. The web page was set up. The frequently asked questions were prepared and got the first approval on Monday, the March 23rd last year, and then started putting the registry in place. It was launched within a record time of 21 days. We had our first 16 sites, so with their IRB exempt or approval status, as well as our first 10 patients enrolled even before the March was ended. Remember, this was the time when all office were being shut down, people were working from home and so on and so forth. So it took us a record 3 weeks of time, and this has been published, a timeline and some other opportunities in this publication led by Dr. Walkie. The registry has its own fair success. Now it has been grown to have more than 125 ideas submitted. More than 65 have been approved. There are at least 25 publications either already published in print or in approval process as well. But our initial first 3 publications, including this one, which we published the protocol or the method of this registry, followed by the second paper, which was the guiding principles of conducting observational studies during the pandemic time, which is freely available for anybody to replicate it. And third, we end up publishing the practice variations or outcome variations utilizing more than 20,000 patient data. Now it has been more than 10 publications in process, and we hope that this registry, through these publications, will be able to shed some lights on these critically ill patients over the next several years, so we can learn, invite more collaboration, and then try to be better prepared for the next pandemic.
Speaking of collaboration, I just want to point out that each of these articles has a longer and longer list of authors. One of the things that I really enjoyed about being part of Virus, Rahul, is how we're including all of the sites in as much publication as possible. I think we have some papers that have several hundred authors on them, isn't that correct? In order to have all sites represented, make sure even those people who are helping with data abstraction are getting some authorship.
That is true, and that's what one of the main point we'll be talking in the end as a lessons learned, that what's in it for me, what's in it for the investigator or data abstractor. So rightly so, Smithy. This slide, as I was talking about, that giving a glimpse of what kind of data needs to be captured. We put down, if you're creating something like that for any pandemic or any major disease for that matter, the buckets of data, which becomes really important when we do manual data collection or automation as well. But I would like to highlight the collaboration, the spirit of collaboration. This registry, through virus COVID-19 registry, we were able to collaborate with WHO through the ISRIC registry itself, the American College of Radiology for being the imaging partner, Point Click Care, our partner with capturing the data of skilled nursing facility patients as well, different medical societies, our collaboration with other societies of American Heart Association, Stop COVID, and a few other things as well. And of course, one of our most cherished collaboration with FDA Cure ID project, as we were talking today. I'll leave you with this summary of what is our global story, and Smitty, please chime in. It's just a global story of 70,000 unique patient data, more than 150,000 patient days, more than 12 million patient data in that data points in that regard. It's a story of volunteers. Each institution has deployed people, the investigator, the scientists, the PhDs, the RNs, and respiratory nurses, and students, medical students, and rotating students in more than 40 US states and 28 countries. As I mentioned, 100 plus ancillary study ideas, 60 plus have been approved. And now it should just give you a glimpse of 25 of these manuscripts either published or in submission or analysis phase. And this infographic, which we are showing it, which got published and got a sizable media attention with 20,000 solid patients, the first and unique one to talk about the different organ support and what their mortality looked like and what was a major factor of variation in their mortality based on which hospital they went to. Smitty, anything you want to share?
Yeah, well, I just want to remind people, as you pointed out earlier, we can go to sccmcovid19.org to see some of these charts and more infographics on the registry itself. And I also want to highlight again that most of the work done in this registry so far has been unfunded, right? A lot of this, as you point out, these are thousands of volunteers that have contributed to making one of the largest COVID-19 registries in the world.
Absolutely. And then, but the core point of this registry is data harmonization and speed of data collection. We started with manual data collection, but we quickly realized that we have to go into automation as well. And I would like Smitty to now take on and talk about some of the opportunities there, that how we were able to actually do that, or still we are doing it in this phase. To you,
I think that was one of our first investigator meetings. When I was at one of the hospital systems participating in virus at that time, and we had a conversation in our all investigators meeting about the need to automate data because of how much we were dealing with, and that's how we formed this subcommittee and started building some of this process out. What we were dealing with is the fact that EHRs are so infinitely customizable. There's so much variation in use at both individual and organizational levels, and they're just not designed for research. And so we went to try to build tools that would let us share and coach each other through the automation process. There's an article in Critical Connections, one of Society of Critical Care Medicine's publications, that talks about some of our early thoughts on the process. When we were still doing one-off automations, as opposed to having moved now into putting some effort on the Edge tool, which I believe there's also a presentation on, but they'll be part of the panel discussion on the third day of this annual meeting. Just to give a scope of what we're dealing with, the virus registry at the time when we were building the automation out had 549 variables. Some of those were repeated up to 17 times, and we estimated for a complicated patient, some patient requiring ICU care, it may take up to 4 hours to abstract this patient's data. And that's just an insane level of effort when we start thinking about how many patients each hospital is dealing with. The hospital that I was at the time we joined the registry had 4,000 patients already. And by the time we were, the last data upload I did before leaving that institution earlier this year included 7,000 patients. If we had had to do that manually, there's no way we could have gotten all that data in. So this data automation task force that we formed, there was originally 38 sites participating in Virus. And we followed some models from implementation science to try to develop tools and resources, and even built frameworks for peer mentoring so that we could coach each other through the extraction process. And what we ended up with was with some shareable tools where many sites were able to replicate what other institutions had done, or able to provide slight modifications, or even just work with Excel macro templates to be able to expedite some of this collection. And we built this visualization of the whole process where data comes out of the system, the EHR, whether that's Epic, Cerner, Meditech, eClinicalWorks, in through one of three pathways. There's either an analyst-driven reporting where you have your IT professional pulling data out, or end-user reporting that's available to physicians, nurses. In Epic, these would be things like Clarity and Workbench. But then there's always a need for manual abstraction, particularly around imaging data or signs and symptoms. So we found that most sites were actually using a combination of this data and then having to go through several steps of transformation before they're actually able to get the data into the Mayo REDCap server, which is where we were loading all data at the time. Through this process, the really exciting thing is that at 10 of these 38 sites were able to automate approximately 80% of the registry within 9 weeks of launching the process. So again, continuing that spirit of rapid innovation and rapid deployment that was present throughout the entire virus registry. There were 3 sites that seemed to be the most successful and automated approximately 90% of the data. At those institutions, the virus registry was part of the core operational priorities. Usually what that meant is that the processes to get data for the virus registry were also the same processes that were being used to get the data to make operational decisions around PPE, around staffing, around unit closures, or setting up designated COVID ICUs. But we found that you couldn't just drag and drop one approach to all the others. One size fit one for the majority of the work we're doing here. And that's what's really exciting about the work that CureID, Virus, and other partners are now doing with the Edge tool. Because having a more drag and drop, much more universal process, not only can we get better quality data, but then your champion is only trying to champion a smaller lift rather than having to completely overhaul the native electronic health record. And as Dr. Kashyap pointed out, there's always a need for rewards, the what's in it for me factor. Do you want to say more about that?
Absolutely, Dr. Hebner. I would definitely like to. So I agree with whatever Dr. Hebner has said so far in this regard. One thing was we realized early that as more and more people want to help during this pandemic, we're talking about early March, April of 2020, where everybody's overwhelmed. They don't know. There were so many unknowns, but people still step forward, and then they wanted to help out. And we had to build rewards for them as well. Idea was, what's it for them, the people who are being the PIs, the data abstractor, the students, and so on and so forth. So we built this strategy that as you're contributing data, you will have access to this data. You can seek it out by submitting in a proposal, and then you can seek out the whole world's data coming through virus registry, or 28 countries or 40 US states. Of course, data will be de-identified. Of course, you cannot compare institution across other institutions and so on and so forth. 2, if data is being used from your institution, we would like to have top 5% site in adult, top 20% site in pediatric. The PI be the part of the club co-author, main co-author list, and everybody else's whose data is being utilized, they will be added as a collaborative co-author. So it shows up in their CV for academic promotion, for their next phase in the career, and so on and so forth. And third, they have access to their own data anytime. For their own institutional data, they can download it, they can request it, they can take it and do whatever they want to do it with that. For their own publication, presentation, no questions asked. We just provided a platform for data harmonization, and they can do anything what they want. So these are the few rewards we had just for the data part in the first 18 months, and so on and so forth. Of course, we have to evolve and look for further rewards as well as we start meeting in person. Some of these abstracts, manuscripts, and grants are coming in, but this is just a beginning that through this great collaboration, the people we have never met before, we have never known before, the virus COVID-19 registry has given this platform for them to come together, work together towards the same goal. Let's find out what's going on and see what can we invest into infrastructure to be better prepared for the next one. I think other than that, I have not much to add, Dr. Havner.
Dr. Kasha, that's a great point about building networks. I think we've all benefited from this registry, expanding not only our connections, but quite a few of us have gotten career advancement as part of this work. So before we wrap up, we just want to point out again, please feel free to reach out to us with any questions. My email is shevner@cpath.org. Dr. Kashyap is rahul.kashyap@hcahealthcare.com. Please feel free to hit us up with any questions and shout out at us on Twitter if you want information about how we did this, if you want to collaborate on other projects, or if you want to join the virus registry itself, please feel free to reach out.
Thank you.